these discussions with Diane Spicer, and Diane is with us again from St. Petersburg in Florida, along with James Quintisenza. And I've also been joined by Justin Tretter, who's been providing virtual dissections. Justin will be with us again. He's now in Cleveland, in Ohio. And we've been joined by Adrian Crucian from Birmingham Children's Hospital. For this series of sessions, I'm delighted to be able to tell you that I'm also going to be joined by Andrew Cook. Now, Andrew Cook is the morphologist who replaced me as the morphologist for Great Ormond Children's Hospital, and he now has a magnificent setup and archive at Great Ormond Street. So I have been working with Andrew to present the first two of the series that you're now going to see. The first one, in fact, was specifically prepared for the echocardiographers at Great Ormond Street. So when Sasha shows you the tape, you will see that we start these discussions with what we presented for Great Ormond Street. You'll be hearing that material. It's me presenting the developmental background, the didactic approach, and then this time, Andrew showing what we can achieve by looking at the specimens. And we're delighted that as a coda to this initial presentation, Justin Tretter has again prepared a series of virtual dissections. We're going to have 4 series considering ventricular septal defects, because ventricular septal defects, as you all know, are the commonest congenital malformations. So we'll have one of those each month. First one this month in August, and we'll have one in September. Then Diane will be back with me in October to present the October session. And I hope that Diane and Andrew, together with Justin, will join me for the November session. And then in December, we'll start a further series where we're going to consider atrioventricular septal defects. So to set us off with looking at ventricular septal defects, let's ask Sasha now to play us our introduction to the understanding of channels between the ventricles. Sasha, back to you for the videos.
Our task today is to give you a means of understanding deficient ventricular septation. Now, Beer has already intimated to you that this arguably is a difficult topic to understand. I'm not sure that that is the case, but what we're going to try to do today is to set the scene for understanding. Now, this is going to be at least a 2-stage process, because today we're going to discuss overall problems in ventricular septation as we move through a series of parts. And we will end up with what you all call isolated ventricular septal defects. So we're going to set the scene for understanding the isolated defects to show you what happens before you get to that stage. And as you can see on my slide, I believe now that the key to understanding is to appreciate what happens during development, specifically as the embryonic interventricular communication becomes remodeled. So here's a potential problem. What is the embryonic interventricular communication? So let me share with you the evidence we now have available to discuss cardiac development. We now have over 450 3-dimensional data sets prepared from mouse embryos. We also have them from human embryos, and these were prepared by my good colleague Tim Mohan, who has now also allegedly retired. More importantly, we now have access to a series of human embryos through the key stages of development that were prepared by Wout Lammers, Jill Hicks-Poors from the University of Maastricht in the Netherlands. And I can back that up with archived material that's available in the Human Developmental Biology resource. And that is housed at Newcastle University, but the Institute of Child Health is part and parcel of the preparation of that archive. So this is Tim Mohan. He initially worked at the Medical Research Institute of Mill Hill. He then moved down to the Crick Institute, and like myself, he's now allegedly retired. But in the background to Tim, you can see one of the exquisite images I'm going to show you very shortly, which is a picture from a three-dimensional data set of a developing mouse heart. This is Wout Lammers, to your right hand. He's presenting the degree of Doctor of Philosophy to Jill Hickspoors, who is on your left hand. And they've produced the most amazing series of interactive PDF files. And they are now available to you on the net. So if you are interested, and if you go to Google and you Google Hickspoors, you will find access to these three-dimensional data sets. And everything I'm going to show you today can be replicated by looking at the images they prepared from the developing human heart. So this is one of the images you can prepare from their interactive PD files. What I've taken here is the cavities of the developing human embryonic heart. CS stands for Carnegie stage. So this is the start of development, Carnegie stage 10. The embryo at this stage is at the end of the 4th week of development. And what you can see in the middle of the slide in pale blue and the grayish area is the developing heart tube. And at this stage, it truly is a linear heart tube. Coming into the caudal part, we see the venous tributaries from the placenta, from the yolk sac. As yet, the cardinal veins from the embryo itself have not developed. So they come together to form the venous tributaries, the right and left sinus horns, and they feed in to the larger part of the linear heart tube, which will end up as being the embryonic left ventricle. Already, however, at the cranial part of the heart tube, we begin to see the beginning of the outflow tract, and that leads into the 2 aortas. So this is the so-called straight heart tube stage. This, however, is the key feature that leads us towards the understanding of ventricular septation, because this is ventricular. You see, we've gone 1 stage forward. We're at Carnegie stage 11. About a day has passed during development, but that linear heart tube has bent, and it's bent to the right, and this is what we call the ventricular loop. Coming into the inlet of the ventricular loop, we have the Atrioventricular Canal. From the outlet of the loop, we have the outflow tract. And at this part, it is a linear cavity. So the key stage that leads us towards ventricular septation is the process that is known as ballooning. And this process of ballooning was developed by my colleagues in the University of Amsterdam, Antoon Moorman, Vincent Christoffels, and they pointed out that from the ventricular loop, you have this expansion from the inlet part of the loop that will form the definitive left ventricle, from the outlet part of the loop that will form the definitive right ventricle. And it is the space between those 2 ballooning components that is the embryonic interventricular communication. The previous image I showed you was a speculative diagram showing you the process of ballooning, but as you can see, it really does happen. So here we've gone a couple of stages forward. We're now at Carnegie stage 13, again looking at the interactive PD files prepared by Wout and Jill. And now we are towards the end of the 5th week of development. But what you can beautifully see now is the Atrioventricular Canal. You saw a moment ago that was leading to the inlet of the ventricular loop. And now, from that inlet, you see the beginning of the apical component of what will be the left ventricle. And then from the outlet of the loop, you can see those few speckles, and they are going to be the beginning of the outlet component of the right ventricle. And now we can recognize where we see the embryonic interventricular communication. Because this is what it looks like when we take one of those episcopic data sets and we cut what eventually will be a 4-chamber cut. So you're looking at the base of the developing ventricular mass now from the apex, and there you are looking into the orifice of the Atrioventricular Canal. And as I showed you just a moment ago, that is opening in to what will become the left ventricle. So now you can see the interventricular communication. And I'm going to call this the primary interventricular communication, because our understanding of deficient septation will depend on knowing what happens to this communication as it is remodeled during the process of development. So at this stage, the entirety of the outflow tract, as you can see, is supported by the developing right ventricle. So that means all the blood from the atrial chambers goes into the developing left ventricle. And then to reach the developing right ventricle, it has to pass through the primary interventricular communication. And this is the key to the start of our understanding of deficient ventricular septation. Because this is that self-same data set. It is three-dimensional. So I've rotated it just a little bit. So now you're looking at it from the front and from the right. And so what you see now is the cavity of what will be the right atrium. But as you see, that right atrium has no connection whatsoever with the developing right ventricle, because the developing right ventricle is incomplete. And there is the primary interventricular communication. So all the blood from the atrial chambers has to pass through this primary interventricular communication so as to reach the developing right ventricle, which at this stage has an obvious apical part and which is supporting the entirety of the outflow tract. Now, in just a moment, we're going to switch, and Andrew is going to show you a replica of this stage. It's not quite the same, because in the half that Andrew is going to show you, there has been remodeling of the outflow tract so that it is separated into the aorta and the pulmonary trunk, and the aorta has been committed to the developing left ventricle. But Andrew is going to show you the replica of this stage, which is classical tricuspid atresia. So remember, at this stage, the primary interventricular foramen is the outlet for the developing left ventricle and the inlet for the developing right ventricle. And it's found in the setting of hearts that have a dominant left ventricle and an incomplete right ventricle.
Thank you, Bob. Yes, so I'm going to show some types of malforms and malformation that hopefully you'll recognize are very similar to the images that Bob has just shown you. So the first case, as Bob has intimated already, is a case of classical tricuspid atresia. And first of all, if you look at the outflow tracts in this heart, you'll see that they are normally related, with the pulmonary trunk crossing over the aorta. They have become completely separated into two arterial outlets. If we open that up, you'll see there's a nice pulmonary valve, smaller than the aorta, but a nice normally formed pulmonary valve. So we have separation of the outlet components. If I turn it over and show you the other side, so show you the right atrium, you'll see that it's enlarged. We have an interatrial communication here, a small interatrial communication with a muscular atrial septum, but you'll see that because of failure expansion, rightward expansion of the AV junction, we have complete separation of the right atrium here from the ventricular mass. And very often you'll find there's a deep sulcus beneath the right atrium carrying the right coronary artery, indicating the complete separation. Now, if I look at that, if you look at that from the right ventricular aspect, and we just close in on that slightly, you'll see that the right ventricle, as Bob has indicated in the embryonic heart, is incomplete. We don't have an inlet component, we have an apical component, and we have an outlet component, which, as we said, is divided. And this defect here, which has begun to close, so if you like, has begun to close postnatally, is the primary interventricular foramen that Bob was describing. So right ventricle on this side, left ventricle on the other side, and here is the primary interventricular foramen, which has not closed during fetal life or embryonic life, but is beginning to close postnatally. And there again, just looking from the other side, here is the left ventricle, so morphologic left ventricle, and you can see there that the fine trabeculations there. Here's the other side of that communication. So if you imagine analogous to Bob's diagrams, we have the atrial chamber, the left atrium, leading through the left to the mitral valve into the dominant left ventricle. And here's the primary interventricular communication, and you'll see that actually it has completely muscular borders, although perhaps now it's beginning to get some fibrous tissue on the margins as it's beginning to close. So you can see how that's analogous to the images that Bob was describing to you. Bob, back to you.
So that is the starting point of remodeling of the embryonic interventricular communication. So the next thing that happens is there is expansion of the atrioventricular canal. Andrew has already pointed out to you that tricuspid atresia reflects the lack of any expansion of the atrioventricular canal. But if development proceeds normally, then the atrioventricular canal will expand rightwards, and this will provide the inlet of the developing right ventricle. But although it has its inlet, it will continue to support the entirety of the outflow tract. With regard to the primary interventricular communication, however, this means there has been a major change, because now with the development of the inlet to the right ventricle, what we are going to see is the secondary interventricular communication. And the secondary interventricular communication will now provide only the outlet for the developing left ventricle, because the expansion of the atrioventricular canal will have provided the right ventricle with its own inlet. So now I'm showing you the outside of these developing hearts. And here you are looking at it from the right and from above. And this is the stage that I showed you just a moment ago, during which the right atrium has no communication with the developing right ventricle. The beauty of these interactive PDF files, however, is you can take away the bits that you don't want. So now you're looking down on the atrioventricular canal. And in these files, Jill and Wout have segmented the different components. So what you see in yellow is the atrioventricular canal myocardium. And that is leading at this stage only into the developing left ventricle. You saw that just a moment ago. So here is the right ventricle. It is ballooning to provide the apical trabecular component, but as yet, it has no inlet. It is, however, supporting the entirety of the outflow tract. But if you look now into the atrioventricular canal, then the atrioventricular canal, you can see the superior cushion, you can see the inferior cushion, they lie edge to edge. And what we've also included in this picture is the limbs of the primary atrial septum. So the space between the primary septum and the cushions is the ostium primum. What you're seeing in purple is the connection between the heart tube and the pharyngeal mesenchyme, and this is what we call the dorsal mesocardium. And that is going to become important very shortly. So there is the ostium primum, and it is the space between the leading edge of the primary septum, the atrioventricular cushions. But remember, at this stage, the atrioventricular canal is looking only into the developing left ventricle. But as we take the situation forward, we can see that expansion of the atrioventricular canal. So here we've got 2 stages forward, Carnegie stage 16. Again, you're looking at it from above and from the right. And now the atrioventricular canal has expanded rightwards to give the developing right ventricle its inlet, taking with it the cushions, reducing the primary foramen. But there is now another key point, because the right side of that dorsal mesocardium is growing into the heart, and that is going to produce the buttress of the atrial septum. We call that the vestibular spine. So now if we take it a couple of stages onwards, rotated the heart a little bit so that you can look now down on the atrioventricular canal from above. And now you see how the atrioventricular canal has expanded so as to provide the right ventricle its own inlet. Remember, still at this stage, the right ventricle is supporting the entirety of the outflow tract. The cushions themselves are fused, but look at what has happened to that vestibular spine. As the vestibular spine has bound itself down to the atrial margin of those cushions, it's closed the primary foramen, and that has completed atrial septation. So this is the situation where the right ventricle has provided its own inlet through what will become the tricuspid valvar orifice. But what happens if that expansion is incomplete? Now that leads us to another key lesion that we're going to look at, and it leads us to the concept of malalignment. Because if the atrioventricular canal does not expand properly, there will be malalignment between the ventricular septum and the developing atrial septum. And that is what we see when we have straddling and overriding of the morphologically tricuspid valve. The ventricular septal defect we see in that setting is perimembranous, because it is roofed by the fused atrioventricular cushions, so there will be mitral to tricuspid fibrous continuity. But because the atrioventricular canal is not expanded, that defect of necessity will open to the inlet of the right ventricle. And now this leads us to what you need to appreciate to understand deficient ventricular septation. We need to know the phenotype. And in this instance, the phenotype is that the defect is perimembranous. We need to know its geography. So it's an inlet perimembranous defect. And then, in this instance, in addition, there will be malalignment. So three features: the phenotype, the geography, the presence or absence of malalignment. Andrew, over to you.
Thanks, Bob. Yes, so before I showed you an example of tricuspid atresia, where there was no transfer of the inlet to the morphologic right ventricle. We had an incomplete right ventricle. And this then is the example really that Bob was just mentioning, where we have straddling and overriding of the tricuspid valve. So we're looking at this first of all from the left side of the heart. I'm going to ignore the outflows in this case. They are abnormal, but we'll come on to the outflow tracts in just a moment. And you'll see here that we've got a mitral valve leading into the left ventricle, but then we also have a tricuspid valve, which is both overriding, which refers to the annulus of the tricuspid valve, and also straddling. You can see tension apparatus here coming across and attaching to the free wall of the left ventricle. So this is actually quite marked straddling and overriding of the tricuspid valve. And you can see that actually if this moved more towards the left or failed to transfer even further, we would then have the spectrum towards double inlet left ventricle. Now, as Bob mentioned already, by necessity, this has to be an inlet defect. And I'll show you that from the right side in just a moment. But what you'll see beautifully from this side is that there is fibrous continuity between the tricuspid valve and the mitral valve next door to it. And that is really the key feature of a perimembranous defect. We know it's perimembranous because of this fibrous continuity. We know that the conduction axis will run, if we have concordant AV connections, it will run inferiorly along the border inferior margin of this defect. But its phenotype is perimembranous. Its location then is primarily within the inlet, although I have to say it's extending towards the outlet as well in this particular example. So here you can see it's quite a big defect. We're looking at it from the right side. And as Bob indicated, there is then malalignment between the plane of the atrial septum and indeed the AV node, normal position of the AV node, and the ventricular septum, which is running downwards here. If we follow the inferior margin of the ventricular septum downwards, we would actually note that the AV node is displaced inferiorly in the setting of a overriding tricuspid valve. So this malalignment has marked implications for the conduction system of the heart, important surgically, of course, but you can see how varying degrees of malalignment give rise to overriding of the tricuspid valve and of course also perhaps to straddling of the tension apparatus. Bob.
So we've now introduced you to one of the isolated ventricular septal defects, which is our endpoint. So to an extent, we've introduced that a little bit early, but it's important that we take that into account because we've now also introduced you to the features you need to take into account when you are analyzing defects between the ventricular chambers, and they are the phenotype, the geography, and the presence or absence of malalignment. But let's go back a moment and let us presume that there has been normal transfer of the atrioventricular canal, and that will provide the right ventricle with its own inlet. And if there has been normal transfer, there will be alignment between the inferior part of the ventricular septum and the base of the atrial septum. The right ventricle will have its own inlet that will be guarded by the tricuspid valve. And as you all know, in normal development, the tricuspid valve drains exclusively into the developing right ventricle. But by that remodeling, the channel between the left ventricle and the developing right ventricle is now the secondary interventricular frame. And that is because the right ventricle has now achieved its own inlet. The key point, however, is that the entirety of the outlet is still supported by right ventricle. So that means the secondary interventricular foramen is the outlet for the developing left ventricle. However, the outlet component itself is beginning to separate. And it separates by muscularization of the cushions that spiral throughout the ventricular outlets. At this early stage, however, those proximal outflow cushions remain exclusively within the right ventricle. Now, pictures, of course, are worth thousands of words. So let me show you what that looks like. I've switched now to one of the three-dimensional data sets from a developing murine heart. And now E stands for embryonic day. So this is the developing mouse heart of embryonic 12.5. And the key stages of murine development are between embryonic day 10.5 and embryonic day 14.5. And the interventricular communication is closed at embryonic day 14.5. But at this stage, the right ventricle has achieved its own inlet. And there, in fact, you can see it. And you can see how those trabeculations are supporting the base of the tricuspid valve, which is now opening exclusively into the developing right ventricle. You can also very nicely see that apical trabecular component of the right ventricle, which ballooned from the outlet of the ventricular loop. The outflow tract is already separated in its middle component, however, to produce the pulmonary route and to produce the aortic route. But the proximal outflow tract has yet to separate. It is beginning to separate, and you can see the evidence of that, because there are the margins of the outflow cushions that are coming together, and they are going to build a shelf in the roof of the developing right ventricle, and that shelf is going to commit the aortic route into the developing left ventricle. But how is it going to get into the left ventricle? It is going to get into the left ventricle by using as its entrance to the left ventricle the interventricular communication. This is already remodeled from the situation we started with, which was the primary interventricular communication. As you see, the right ventricle now has its own inlet. So now we can call this channel the secondary interventricular communication. But what would happen if development is arrested at this stage? Remember, both of the outflow tracts are supported by the developing right ventricle. The left ventricle has its outlet through that secondary interventricular communication. So if we stop development at this stage, we would have double outlet right ventricle with a subaortic interventricular communication. Now, this is key to understanding what is going on in your setting, because the defect provides the outlet for the left ventricle. And hence it cannot be closed. If you come across patients having double outlet right ventricle, you can never close that channel. And in fact, you ask the surgeon in this setting to tunnel that channel into the aortic root. And that is because it is the same situation we see in the embryo. It is the secondary interventricular communication. So let's look at that, Andrew.
Thanks, Bob. Yes, I'm going to show you a heart, first of all. I'll come into a second one in a moment, perhaps, but a heart where we've got division of the outflow tracts, as Bob has said. So this is the aorta behind the pulmonary trunk, typical arrangement of the two great arteries. You'll see the aorta is slightly smaller than the pulmonary trunk. And there's a reason for that, as we'll see inside. If we look at the left ventricle, see the fine trabeculations there, and you can see that the only outlet from the left ventricle is here by what Bob was just calling the secondary interventricular foramen. So this is interventricular communication, but clearly there's no outlet from this heart. And when we look at the right ventricle, you will see that actually both outlets are coming from the morphologic right ventricle, analogous to the embryonic hearts that Bob was showing you. But in fact, we've got restriction, we've got stenosis beneath the aortic valve. So we've got some muscular stenosis here. This is the outlet septum, which is exclusively a right ventricular structure. And in a way, this heart is trying to close its secondary foramen in another sort of manner. So there's the secondary foramen. You can see that it is subaortic, although it is perhaps a little bit further down than in other hearts. So it's a little bit distant because of this subaortic obstruction here and this subaortic muscle here. But there is the interventricular foramen. You can see that actually effectively this heart is arrested at an early stage in development. There's been division of the outflow tracts and is now then trying to close its secondary interventricular foramen, which, if it happened, would lead to double outlet right ventricle with an intact ventricular septum. Bob.
So that was absolutely beautiful. It matched very much what I showed you just a moment ago with that developing mouse heart. You could actually see the similarity between the two. Now, what happens during normal development? Well, those proximal cushions muscularize. And it is interesting that the embryo does exactly what you ask the surgeon to do when the surgeon is asked to repair double outlet right ventricle. Because those proximal cushions muscularize and they produce a shelf in the roof of the right ventricle. And that shelf in the roof of the right ventricle creates a channel between the aortic root and the left ventricle. And that channel has the secondary interventricular communication at its left ventricular end. So let's look at that. So this is another mouse heart, embryonic day 12.5, but I've cut it in a slightly different fashion. You can see that there is the Atrioventricular Canal there with the cushions in it. The cushions, in fact, at this point have yet to fuse. But I've cut it through the subaortic outflow tract. So to your left hand, you see the developing right ventricle, and there is the developing aortic root. So I've cut it now in such a way that you can see that secondary interventricular foramen. And the picture shows you beautifully that the blood that is coming into the left ventricle, in order to get into the aortic root, has to pass through that secondary interventricular communication. So in fact, we can never close that secondary interventricular foramen if development is to be normal. And so this is what the embryo does. This, in fact, is the same heart, because I've just produced the cutting plane a little more anteriorly within the heart, and I'm showing you what the embryo is doing to convert that secondary interventricular communication into the left ventricular outflow tract. Because these are the proximal ends of the two cushions that are separating the right ventricular outflow tract. We call one the parietal cushion, we call the other one the septal cushion, And in this picture, you see they have fused. And so the embryo now has built this shelf, which is producing a channel between the aortic root and now separating the aortic root from the developing right ventricle and putting it into communication with the developing left ventricle and using secondary interventricular communication as the left ventricular outflow tract. And it is exactly the same in the human heart. So I've taken you forward quite a bit. You see, we're at the end of the 7th week of development in the human embryo. This is Carnegie stage 20. You're looking at the developing right ventricle from the right side to show you what's going on. Still, we have the Atrioventricular Canal myocardium shown in yellow. These are the developing leaflets of the tricuspid valve, and that is exclusively looking into the developing right ventricle. And there you see the right side of the muscular ventricular septum. But now we have reconstructed the intrapericardial arterial trunks and the developing arterial roots. And the developing arterial roots are supported exclusively by the right ventricle. But in the human heart, as in the mouse heart, the secondary interventricular communication is going to become the left ventricular outflow tract. And so, just as I showed you in the mouse, those proximal cushions have muscularized. They've come together, they've fused, they have muscularized, and they have built the shelf so as to put the aortic root into communication with the developing left ventricle. And that is now complete at the end of the embryonic stage, 8 weeks of development. This is Carnegie stage 23. And now, there in the light blue, you can see the channel that is connecting the aortic root into the left ventricle, but the aortic root is still at this stage aligned with the right ventricle. So to complete the situation, the heart now closes off the channel between the aortic root and the developing right ventricle, and that channel is now the tertiary interventricular communication, because remember, the secondary interventricular communication is being remodeled to produce the left ventricular outflow tract. And so there you see now the tertiary interventricular communication. There is the aortic root. It is overriding the crest of the ventricular septum. The secondary foramen can never be closed. It is the tertiary interventricular communication that will be closed by the membranous septum to complete ventricular septation. So formation of the membranous septum will close the tertiary foramen. Those muscular cushions will become the freestanding infundibulum, and it really does happen. So here you can see it at the completion of septation. That is the pulmonary root. There is the channel connecting the aortic root to the left ventricle, and there are those tubercles of the atrioventricular cushions that will form the membranous septum. And it is failure to close that tertiary foramen that will give us the isolated perimembranous ventricular septal defect. Its phenotypic feature will be continuity between the leaflets of the atrioventricular valves. And the reason you get a perimembranous defect is because of deficiency of the surrounding muscular septum. And that's why perimembranous defects can open centrally, they can open to the outlet, they can open to the inlet, they can be associated with malalignment, or they can be confluent. Andrew.
Thanks, Bob. Yes, I'm just going to show you one quick specimen, in fact, which indicates what happens when that tertiary foramen is not closed fully. Now, this is a very typical sort of defect that you're going to see in your echo clinics, I guess, quite frequently. It is a small defect. You'll see that it's very centrally placed. It's between the commissure of the anterosuperior leaflet and the septal leaflet of the tricuspid valve. In fact, it's bridged a bit by valvar tissue there. But if we peek below there, you'll see that there is a very small deficiency there of the ventricular septum. The final part of that shelf has not formed correctly, which would form the full membranous septum. And And so you can see the defect there, and you can also see how it could be easily closed by tricuspid valvular tissue, which could seal that shut on the right ventricular aspect. There are separate outflow tracts, so coronary valve here, we can't see the aortic valve on the other side, and you can appreciate here how the other structures that Bob was describing to you have fused together and effectively have formed the right ventricular outflow tract, effectively have separated most of the right ventricular and left ventricular outflow tracts. So we sometimes refer to all of these as the supraventricular crest, made up of the ventricular fold, the infundibulum of the right ventricle, the crest of the septum, and then the septomarginal trabeculation with the forming membranous septum, incompletely forming membranous septum in the base there. And just showing you that from the other side, we can see that there is a margin of fibrous continuity. It's small, but there is a margin of fibrous continuity between the tricuspid valve on this side and the mitral valve on this side. There's also continuity with the aortic valve. So this is the tertiary foramen. We certainly wouldn't close the secondary foramen, which in fact is this margin here. So there are some analogies then with hearts with central perimembranous VSDs. But as you know, that VSD can extend to the inlet. There can be excavation of the ventricular septum more inferiorly, or it can extend towards the outlet, as you might find, we're going to see in a moment, in Tetralogy of Fallow.
So you've just seen beautifully what happens if the tertiary interventricular communication doesn't close, but is relatively small. There is another reason, however, why the tertiary foramen can never close, and that is because on occasion the aortic root is incompletely transferred to the left ventricle. And then the muscularization of those proximal cushions will give us a structure that remains within the right ventricle, but which will be malaligned with the apical part of the septum. And you've seen that the apical part of the septum is produced by that ballooning, the apical trabecular components of the left and right ventricles. So in normal development, those muscularized proximal cushions produce the subpulmonary infundibulum. In abnormal development, they will produce a right ventricular outlet septum. And the essence of this, with overriding of the aortic root with the right ventricular outlet septum, is either Tetralogy of Fallow, when we have obstruction of the subpulmonary outflow tract, or the so-called Eisenmenger defect. And in this setting, it is the tertiary defect that is closed by surgeon. So let me take you back to murine development. You've seen this just a moment ago. Andrew has shown you this in the setting of the isolated perimembranous defect. So remember, the secondary interventricular communication becomes the left ventricular outflow tract. Andrew has shown you that beautifully. It is the aortoventricular communication between the aortic root and the right ventricle, the tertiary interventricular communication that is closed by the embryo and is also closed by the surgeon when we have overriding of the aortic root because it has been incompletely transferred into the left ventricle. Andrew.
Thanks, Bob. The last specimen I'm going to show you then is an example then of malalignment. We're talking about malalignment now of the outflow tracts. So remember, when we're talking about VSD, we should have at least two terms, which are the borders of the defect. And you'll see in this case that we have a perimembranous defect. The defect is running back onto the tricuspid valve, and we have tricuspid to mitral continuity in the floor of the defect. It is an outlet defect because we look at the location of this. This is above the level of the tricuspid valve, so above the annulus of the tricuspid valve opening to the outlet of the right ventricle. So those two things are set in stone. But then in addition to that, the third level of categorization, we have malalignment of the outflow tracts. And you'll see here that we've got this bar of muscle within the right ventricle. It's effectively swung out of the plane of the ventricular septum, rotated around, and now is obstructing the right ventricular outflow tract, creating the anatomy of tetralogy of fallow. So it is, as in double outlets, as we looked at earlier, it is exclusively a right ventricular structure. Clearly, the surgeon would not close this defect, this hole here, and instead, as Bob has indicated, he or she would have to close the the tertiary foramen, which is here on the right ventricular border of the defect. So effectively, along the line of the outlet septum, and then running down and probably inferiorly within the right ventricle. So let's just look at that briefly from the left side. Here you can see the overriding incomplete transfer, if you like, of the aorta. So it's sitting on top of the ventricular septum, 50-50 coming from the right and the left ventricle. And there you can see the fibrous continuity between the tricuspid and the mitral valve forming the inferior margin of the defect. So VSD with malalignment, an outlet perimembranous VSD with malalignment of the outlet septum.
So what we have shown you is the remodeling of the embryonic interventricular communication. And what I hope you're seeing is that the dorsal or the posterior part of that primary communication becomes the right atrioventricular junction. That leaves the remaining part of it then as the secondary interventricular communication. And that intermediate stage, secondary interventricular communication, is the outflow tract to the left ventricle. And indeed, it then remodels to become the outflow tract to the left ventricle. And that has then left us the persisting communication between the aortic root and the right ventricle. And that persisting communication is the tertiary interventricular communication. And it is that tertiary foramen that during normal development is closed by the membranous septum. And that is the remodeling that we want to share with you, that we hope will permit us in our next session when we come on to discuss isolated ventricular septal defects. Because in isolated ventricular septal defects, the first two parts you see there, the remodeling of the inlet, the remodeling of the outlet, have happened normally. The right ventricle has its own inlet, the left ventricle has its own outlet, but there is a persisting communication between the ventricles that is the equivalent of the tertiary interventricular communication. And it is the variation of that tertiary foramen in terms of its phenotype, in terms of its geography, and in terms of the presence or absence of malalignment that will permit us to explain to you the variations in isolated ventricular septal defects.
We're going to review 3 data sets of infants with different forms of interventricular communications. The first, a patient with tetralogy of flow. The second, a patient with double outlet right ventricle tetralogy type. And the third, a patient with double outlet right ventricle with interventricular communication committed to both the pulmonary and aortic root. So this is the first infant with tetralogy of flow, and we're viewing in a right anterior oblique view, the right atrium, the right ventricle. And here we can appreciate the aortic root, which is overriding the plane of the interventricular communication. The interventricular communication is cradled within the limbs of the septomarginal trabeculation with its anterior cephalid and posterior caudal limbs. The outlet septum, which is seen here, is divorced from within the limbs and is anteriorly deviated under the pulmonary root into the right ventricular outflow tract, causing subpulmonary stenosis, along with hypertrophy of the septoparietal trabeculations. And if we dissect into the data set, then we can start to see that there's deficiency of the posterior caudal limb near where the medial papillary muscle is attaching. And this is allowing fibrous continuity from the septal leaflet of the tricuspid valve through the interventricular communication into the mitral valve. So this is a perimembranous ventricoseptal defect, which extends into the outlet of the right ventricle. So a perimembranous outlet ventricoseptal defect with anterior malalignment of the outlet septum, the most common form seen in tetralogy of flow. And so the secondary interventricular communication, which represents the left ventricular outflow tract, is seen here. The tertiary communication is that which extends the deficient septation from the crest of the ventricular septum to the outlet septum, seen here. If we dissect into a short axis view and look at the aortic root and relate it to the crest of the ventricular septum, we can figure out that the aortic root is primarily committed to the left ventricle, seen down below here, with over 50% of it committed here to the left ventricle. So this defines it as being tetralogy of flow, as opposed to double outlet right ventricle, where it would be over 50% committed to the right ventricle. And if we dissect down into the plane of the interventricular communication, we can again see the outlet septum, which is anteriorly deviated. Not a great data set, but this is the infant with double outlet right ventricle tetralogy type. Again, the right atrium, here's a septal leaflet of the tricuspid valve, and then a very hypertrophied right ventricle. Here are very hypertrophied septal parietal trabeculations, along with a very prominent outlet septum, which is hypertrophied and anteriorly deviated, creating severe subpulmonary stenosis. And within the limbs of here, the septal marginal trabeculation with the anterior cephalad and posterior caudal limbs, again, is this interventricular communication opening into the outlet of the right ventricle. So an outlet ventricoseptal defect. On the CT data set, it's difficult to appreciate the borders of the defect, but this too is a perimembranous defect with fibrous continuity here between the tricuspid to mitral valve. But as opposed to the last data set, if we bring the aortic root into its short axis here, so here's the aortic root, and we go down to the plane of the crest of the ventricular septum here. So if we come back up and you pay attention to that plane, then in this infant, the aortic root is primarily committed to the right ventricle. Here's the plane of the crest of the ventricular septum. So it's over 50% committed to the right ventricle, as is the pulmonary root. A little more difficult to see the pulmonary root, but if we come down, you can see this little pinhole, which is the right ventricular outflow tract. Here's that anteriorly deviated and hypertrophied outlet septum, which is along with the septal parietal trabeculations, which are hypertrophied, is causing severe right ventricular outflow tract obstruction. But both great arteries are committed to the right ventricle, so this is double outlet right ventricle tetralogy type. And then this last data set is another infant with double outlet right ventricle, so a much nicer data set relating to the heart rates of the two infants. And here's the right atrium. We can see a secundum ASD with this venous line coming down into the right atrium from the SV superior caval vein. And then here's the tricuspid valve, and then the right ventricle with its inlet, apical trabecular, and outlet components. And this is the septal parietal septal marginal trabeculation with its anterior cephalad and posterior caudal limbs. In this infant, we can see very clearly the posterior caudal limb is completely intact with muscle. So there's muscle dividing the septal leaflet through the interventricular communication into the left ventricle from the mitral valve. So a muscular border here. And then there's muscle between the pulmonary and aortic valves. So completely surrounded by muscle, but opening up to the outlet. So this is a muscular outlet ventricular septal defect. So this is the interventricular communication. The deficient septation is represented by the crest of the ventricular septum up to this structure here, the outlet septum. So that would represent the plane of the tertiary interventricular communication. And this outlet septum is more or less bisecting the plane of the interventricular communication, but is slightly posteriorly deviated underneath the posteriorly positioned aortic root, and causing subaortic obstruction, and why this aortic root is relatively smaller compared to the anteriorly positioned pulmonary root. And then if we rotate this into a short axis, looking at the great arterial roots. So here is the aortic root, which is positioned posterior and rightward to the relatively larger pulmonary root. And if we go down to the crest of the ventricular septum here and back up, so the crest of the ventricular septum was positioned here, both great arteries are committed to the right ventricle. So double outlet right ventricle, almost like the example we looked at before, the tetralogy type. However, because this outlet septum is posteriorly deviated, it positions the interventricular communication primarily opening up to the pulmonary root.
Okay, Bob.
Oh, thank you. So there we have it. You've seen the presentation given by Andrew and myself, Justin's coda. We've had one question already from Mateo Rios Valdez, who asks, in tricuspid atresia, the VSD would be persistence of the tertiary foramen. That is not the case, in fact, as I hope Andrew showed you. In tricuspid atresia, because there has been no expansion of the atrioventricular canal, that defect is the primary interventricular foramen. It is never membranous because it has exclusively muscular borders. It can on occasion have a fibrous superior border, and that is when there is fibrous continuity between the leaflets of the pulmonary aortic valves due to failure of muscularization of the outlet septum. That is very rare. Almost always in tricuspid atresia, it is a muscular defect and it represents the primary interventricular foramen. So there is the question we've had from our audience. Norman, why don't we go over to you for your considerations on what we have shown you today?
Well, thank you very much, Bob. I wonder whether Sasha can start my video, because it seems that I'm unable to do it. It says unable to start video. So Sasha, if you could just start my video, I'd be grateful. So whether you look at me or whether you don't, I think the most important issue here, Bob, is that we have looked at the classification of interventricular communications on a temporal basis related to embryology, which is so beautifully described today in all of the examples, that when you look at the defects as you've described them, not only are the borders important in defining the defects, but that you can actually look at these defects as being different in time in their development. And I think that's been the most important contribution of today's session. Thank you, Andrew, for those beautiful examples. I think that they're very clearly described, and Justin, as usual, you have been phenomenal in being able to synthesize these three-dimensional data sets for us. There are just a couple of points that I think are important in terms of maybe tetralogy that I think are important, and that is whether there is a muscular bar posteriorly, and I think that we can see that. Now, as far as I understand it, about 70% of patients, plus or minus a number of percentage based on the series, have a tetralogy, a perimembranous extension of the ventricular septal defect. And of course, that's important for the surgeon, because not that he won't be able to see it, but it gives him a sense of security to know that the conducting tissue, as Andrew had described it, will be exposed in a great deal of the tetralogy patients that he sees. And also, the other thing that I think was so clearly indicated by Andrew's examples was that, and we seem now almost to say that when we talk about double outlets, which is a whole different ball game, we talk about the double outlets today of the tetralogy type. And in fact, there isn't a whole lot of difference between the two in terms of what we look at. And now I have to bring up this very unfortunate point, which is the question of the mitral aortic fibrous discontinuity. And I think that that's something that we've actually we haven't talked about it today, but it's clearly not the important issue in double outlet. On the other hand, the problem that I got into with Professor Talgeva was he showed that in the heart that is beating, there is a dynamic relationship of the interventricular communication to the great vessels as the heart spirals in a clockwise and counterclockwise direction, so that they are never really, you have to define at which area you're looking at that. Obviously in autopsy material and in the specimens that Bob's shown us, there's just one point in time. But I think that we have to appreciate that, that in the real heart, as the heart moves, that the top and the bottom of the heart are moving in counterclockwise and clockwise directions opposite to each other, so that the position of the ventricular septal defect related to the great vessels may change.
I mean, you make some very good points there, Norman, but I think Justin showed you now, using three-dimensional data sets, you can look down the short axis and you can show the crest of the ventricular septum. And I'm not sure that the twisting you describe will change the relationship between the chord of the septum and the short axis of the aortic root or the pulmonary root. And that, to me, is the key point, as Justin showed so beautifully.
Well, I agree. I just wanted to mention that even Justin's specimens are frozen in a point in time.
Oh,
Isn't that right, Justin?
I'm not sure Justin is Justin with us, Sasha?
Yes, I am.
Okay.
I'm not prepared to show you. I have many 4D data sets, and we can look at this in the dynamic heart as well. And in fact, today we'll be getting a CT scan of a patient with a complex apical muscular VSD for interventional planning, and it'll be a 4D data set. So I have plenty of that we can look at. But you talk about what Bob had mentioned. There's the rotational torsion, the dynamic torsion of the root. There's also a change in the tilt angle. As we go from systole, it goes from being about 10 degrees to being almost straight up to improve that efficiency of left ventricle outflow to aortic roots. But neither of those do I think will, and we can look at this after, neither of those I think are going to significantly change, as Bob said, the relationship of the roots to the plane of the ventricular septum.
And whilst we've got you there, Justin, I think the other point that Norman made about the presence of the muscular posterior inferior rim, many people have not paid a great deal of attention to that. I mean, your cases showed beautifully how you can see that with computed tomography. You've also got experience with echo, as does Norman. I guess it's easier to see it now with the CT files than it ever was with echo.
I think it's still easy to see it echocardiographically, but I think that's important that as an echocardiographer, you have to direct your attention to finding whether there is a posterior muscular rim, whether the tricuspid valve is close to the aortic root or far away. And I think that also the offsetting of the mitral and tricuspid valves in the four-chamber view also helps to tell you that, so that if the offsetting is not present, that the tricuspid and mitral valves are on the same level, one can assume that there is than a deficiency of the posterior muscular inferior rim. So we're
Yeah,
using
Norman, if you
data
can
that
see
we
it-
understand.
Norman, let me just stop you for a moment, because if you can see it so easily, why has not more attention been passed? Andrew, as you know, was with you recently in California. He came through CHOP, and Andrew and I were discussing this when we met last week. And Andrew commented that at CHOP, they still talk about conoventricular defects. Yet a
Oh my God.
conoventricular defect can have a muscular posterior inferior rim. It can have a fibrous posterior inferior rim. Andrew, you might like to comment on this.
Well, I mean, a comment from the point of view of finding the inferior rim. Yeah, surely. You can. I mean, it comes to on echo. It comes to Norman's point, really, that you know, you can't just rely on one view. You've got to look in different views, long axis views, short axis views. And I think as people get used to perhaps recognizing the two things that you need to describe as a minimum to describe ventricular septal defects, the borders and the geography, I think people will look for these borders more frequently. So yeah, I think it's practice, but in, you know, I mean, if we avoid the controversies on nomenclature, you know, conoventricular defects, and we go along the proposed classifications, then it's a matter of just practicing and looking for them. I think everyone recognizes that those margins are very important. That would be my view. So again, as I emphasize, you know, if you've got two things, describe the location and the borders, I think that's sufficient. Whichever one you want to put first is up to you. But that should be the prime classification. And as you know, Bob will be talking about the sort of next level of classification in the next video, won't we?
We will indeed.
In the next part of the series.
We have Dr. Quinticenza with us in St. Petersburg. Q, do you ask them to tell you whether there's a muscular posterior inferior rim or not?
We certainly ask for it, but you know, I think as we get more precise in all this, our descriptions are getting better. At the time of surgery, it's fairly, you know, I wouldn't say simple, but we do a very careful analysis, and we can see the muscular bar. And it's actually a nice thing for the surgeon to say, oh, I'm kind of relieved of the risk of conduction tissue as I'm closing this defect, you know, when we see the 20 or 30% of outlet defects. So I think it's a combination of what we get from preoperative imaging, and the better we do with that, the more we know in advance, and then also what we do intraoperatively. It's a very careful, you know, inspection evaluation we have to do before we start cutting or put stitches in.
Have you always described the presence or absence of that muscular rim in your surgical reports?
Yes, usually I would say as an outlet muscular defect, you know, during the, yeah.
And we've got Ross with you sitting behind you. Ross, would you also take note of that entity?
Yes.
Can I weigh in? I wanted to mention that's where Dr. Quinticenza and my friendship began. Is I went into the preoperative TE, and he was the first surgeon at Cincinnati to ask me in a tetralogy of flow patient if it was a muscular defect or perimembranous defect. So I can confirm that Dr. Quinticenza certainly pays attention to that detail.
But Andrew, you had thoughts about that.
Well, I know I was just gonna follow on actually from what Justin was saying slightly, and ask you know, the surgeons, what if you had a defect with a very small muscular rim, which potentially the muscular inferior rim potentially would be a muscular defect, muscular outlet defect, let's say. How would you consider that during surgery? Yeah, let's say you had a millimeter of muscular rim that you could see. Would you clearly wouldn't put your sutures in that muscular bar. It's a muscular outlet defect, but you would treat it presumably as a perimembranous defect. Is that correct?
Yes, so we would, if you felt your sutures were going to penetrate conduction tissue because the bar was so minimal, then you would transition the suture line to the septal leaflet of the tricuspid valve, knowing that the AV node is actually going to be more kind of superior in that setting, right? It's not going to be in the typical inferior posterior. It's going to be more, superior in a way. But the point is, you're going to avoid placing your sutures in muscle if you think you're going to injure the conduction system, and just stay within the tricuspid septal tissue.
Yeah. So treat it as perimembranous. Yeah.
Sasha, do you have any thoughts along those lines?
Don't see Sasha anymore.
Where's Sasha
Bob.
gone?
While Sasha is coming back, I think I maybe can answer your question that you posed to me and left me hanging. And that is that why is it that we haven't paid more attention to this entity? I think because it hasn't been enforced as something that's recognized, and from your morphology, it's become important that you can recognize whether the defect has a perimembranous extension, tetralogy, yes or no. And I think that that is an important issue, and one of the perhaps important reasons why I'm here is to bring morphology into the realm of echocardiography.
The other point you made, Norman, is that so much attention in the past had been placed on the presence or absence of a subaortic infundibulum, and yet
Correct.
that subaortic infundibulum can exist when there is still a perimembranous or a muscular rim. So probably the focus was on the wrong thing in the past.
Correct.
The focus is on the aortic to tricuspid continuity. Yeah.
Well, thank you very much once again for a spectacular session, Andrew. It was great having you. I also would like to see more of Diane. She does such a wonderful job as well. And I thank Andrew and Justin for their contribution, and Bob. The only thing I can say about your session, and that is so important for us in the Congenital Heart Academy, for all of the presenters, is that this is recorded, and it is available, or will be available in a few days for a review. And I think that the information has been so dense that it really does behoove us to go back and look at the session one more time and understand what each of us are thinking about this, and solidify our own concepts of the defects of membranous septation.
Well, I can perhaps emphasize the point you make there, Norman, because you say, are we going to see Diane again? In fact, at the end of the session that we've just had, I suggested that in our next session, we would move to the isolated defects. In fact, we're not going to do that in the next session, because Andrew and I have been expanding on the notion of malalignment, because we also want to introduce the concept of common AV junction versus separate AV junctions. So our next session in September will be Andrew and I doing that, and then Justin again will be emphasizing the significance of malalignment. But then in October, we're going to go back to Diane, and I'll have been with Diane by then. Justin, Diane, and I are going to be together in the USA at the end of September. So we'll be discussing all of that. And then, as I said, hopefully in the final one of our sessions, we'll all try and come together. So we'll have the best of the specimens that Andrew can provide, the best that Diane can provide. We'll have Justin backing it up, and we'll try and summarize the whole thing that we will have been developing through September and October. And of course, we will count upon you to give us your wisdom and to put it all into the era of echocardiography as we move into the era of computed tomography.
Okay.
Did we have Adrian with us today, or was he busy?
He's not looking, he's not seen on the panel, Bob.
He's not.
He is on the panel. His microphone is not
Adrian,
working.
are you with us?
Yes, I was all the time.
Ah, well,
You couldn't escape.
Where are you?
where are you? We can't see you. Come into view.
I can see all of you.
There you go.
Welcome. Sorry.
Hello, Adrian.
So
We did not mean to ignore you, Adrian.
Oh,
Please.
don't worry. You can't escape me, Prof. Because I have many questions, and I will ask them privately because I need them addressed next time. But I would encourage everybody to start with doing this.
Right. Yes.
Because if they get a strip, I don't know how much they understood of what happens with those interventricular communication, and especially the dorsal part. But if they get a strip, if they consider, for example, that this will be the atrioventricular canal into the left ventricle, and this will be the primary interventricular communication, and this will be the outflow tract, they will understand why there is a dorsal part of this atrioventricular communication, and they will start understanding how that remodeling happens. I'll take this with Andrew on a project maybe, because we need a 3D modeling in time to understand this process. I don't think in the current PDF files, the understanding is very clear. So that's first thing. The second thing, this phenomenon, when we say arrested development, we have to understand that if one of them arrests, the others can go on. In tricuspid, and people might understand that they are linked to a certain degree, but they also go independent.
I mean, you might have noticed, Adrian, that I put arrested in inverted commas, because of course, the thing is never truly arrested. Everything goes on, and it's to make that analogy. But if I come back to you for one moment, the model that you created is exquisite, because you can take the interventricular communication from your model, and the primary interventricular communication is a Mobius strip.
Yes,
and
exactly.
you can then modify the Mobius strip so that it becomes in part the inlet of the right ventricle and the outlet of the left ventricle.
I did this while watching the amazing presentation that we had, but I think it's useful to put them in a 3D reconstruction.
And it's the point you made also about the Jill Hicksbors and Wout Lammers. In fact, one of their students prepared a presentation that's available on YouTube discussing exactly what you've just said, the remodeling of the Mobius strip. So they have discussed that, although I'm not sure how many people have looked at it.
I think it's because today we had more of a theoretical session, and it's good if we get this right. Now, on the interventricular communication, we also have to emphasize that they are actually tunnels.
Correct.
They are not simple holes. And
correct.
The secondary one is actually the left end of a tunnel that becomes the left ventricular outflow tract. So it's important to get that right. And am I correct to say that in a double outlet, in the case that we discussed with our subaortic interventricular communication, the muscularized proximal cushions, they will become the outlet septum?
Correct. Correct.
Yes? Because I think it's good if we emphasize when we get to pathological hearts what the embryological blocks are becoming.
Absolutely.
Because it's very easy to get into the normal heart nowadays, and thanks to you and to others' efforts, but it's now the time to emphasize whenever we discuss a pathological thing.
And that's one of the things, in fact, we've already prepared. Andrew and I have prepared that already for our next session, and we will show you exactly what you've just suggested.
And the last thing is about malalignment. Of course, this would be a difficult topic, whether it's outlet or, because when we discuss about the expansion of the dorsal part of the atrioventricular canal, we have to think what happens with the interventricular crest, because this is a malalignment that happens between the interatrial septum, the interventricular muscular crest, and the orifice of the atrioventricular canal. There are many things that can get malaligned there. Not talking about the outlet side.
Oh, indeed. Exactly. And that also, Andrew and I have already touched on, because we're going to demonstrate that in the setting of common atrioventricular junction, as well as in the setting of separate atrioventricular junctions.
Because then it becomes important for us in terms of hypoplasia of the structures and what the tricuspid valve does in terms of following the ventricle or following the orifice. And we have a dogma there that we always said that the valve follows the ventricle, but sometimes it remains asynchronous or not in the same phase with the ventricle.
Indeed.
Thank you.
Does anybody have any final comments? Justin, do you have any final comments?
No, nothing more to add.
Andrew?
No more at the minute, Bob. I think people will be interested in the next in the series. Yeah, with malalignment.
Diane, it's from St. Petersburg. I'll warn you well in advance what we're hoping to do for the October session so that we can get our ducks in a row, as you say, when I'm with you at the end of September.
No further comments, but I'm sure we'll be able to produce whatever's needed.
Well, thank you very much for being with us. And Q, Ross, good to see you guys. Hope to be with you shortly at the end of September.
Look forward to it.
And thanks to everybody else for being with us. As Norman says, if Norman is still here, it is available on YouTube. It's worth watching again. And we hope you'll be with us again September, just before we head for USA. Norman, any final comments?
I know, Bob, I think you've said it all. Thank you.
Well, thank you all for being with us. And we look forward to seeing you again in September.
Thank you very much. Bye, Bob.
Thanks very much.
Bye. Goodbye.
Bye.
Hi, Sasha.
Thank you.
Goodbye. Thank
Thank you very much. Bye-bye.